100 converted in Derbyshire, we normally see round about 8%, so 8 in every 100 who are referred with suspected cancer end up with a cancer diagnosis. And it's that conversion rate, together with the number of actual referrals, that gives us our number of expected cancer diagnoses year on year. And that's what tells us that there are potentially, if we work on the England slightly lower conversion rate, just over 400, but if we work on our usual Derbyshire conversion through a variety of routes, we would love it if everyone came through the screening route, because by the nature of screening, that's people who are asymptomatic, so they therefore must have early disease if they've got it at all. And so they're likely to have the best prognosis. They can also obviously come through their GP practice and be referred to hospital. They may present to accident emergency with a symptom which turns out to be a cancer symptom and ends up in a diagnosis of cancer, or it may be an incidental finding. They may be admitted with something else, and through scanning and investigations that are done, a cancer is diagnosed. So hold on to the thought that it's the first two we really are wanting to push the numbers up with, because they're likely to present at an earlier stage in their cancer and therefore do better in terms of survival. In terms of tests and treatments, we decide who we refer from general practice into hospital based on NICE guidance. So National Institute of Clinical Excellence, NICE, they make various statements around national guidance on all sorts of issues around health, including cancer. And in 2015, they updated their latest guidance on referring people with potentially symptoms suspicious of cancer. These are actually set very wide. If you looked at the positive predictive value, which is, what is the value of any one test? If you referred 100 or one symptom, if you referred 100 people with one of those symptoms, how many of those are likely to have cancer? And it's actually set at a very low rate of 3%. So only 3 out of every 100 referred would you expect to have cancer. And that's done quite, positively, because we want to set the bar low, because we don't want to be missing cancers and then those people presenting later and having a poorer prognosis. If a GP sees someone and they've got symptoms that are slightly worrying but they don't fit the NICE guidance, then hopefully that GP will say, this is what you need to look out for. If this happens or changes, please recontact me. And that's what we refer to as safety netting. So we refer these people. We may refer them directly into a service, or we might refer them for a further diagnostic test like an X-ray, or we might do a blood test within our practice or again at the hospital. We might not be that sure about whether we need to refer them or investigate them further. And so secondary care provides a thing called advice and guidance, which is exactly what it says on the tin. So as a GP, I can send electronically a request for advice about a patient to a particular specialist, and they can send back, either some guidance, which might be, please do test X, Y, Z, or it might be, actually, I think we need to have a look at this person. And so that's very, very useful. And patients are then referred into pathways, and increasingly these are straight to test pathways, rapid pathways, because anyone who's ever been referred to hospital querying a cancer diagnosis will know that that wait time is probably worse than when you're actually given your diagnosis. It's that uncertainty that nobody deals with very well, and that's just human nature. And I think that's why people have found this year so difficult, because there's been so much uncertainty. And in 2014, we realised that actually the health service was doing brilliantly. Unfortunately, we also recognise that more and more people are diagnosed every year with cancer, and you'll have heard people say, if you were born after 1960, 1 in 2 of you will get cancer at some time in your lifetime. And unfortunately, increasingly, people are surviving their first cancer to go on and get a second or maybe a third cancer. And so it was recognised that there was a large group of people surviving cancer and needing to be supported with perhaps late effects of their treatment or their surgery, or just the psychological effect of having to live with a cancer that's not curable, but is having maybe some palliative treatment. Can we go on to the next slide, please, Merriman?
Let's move, Louise.
Thank you. So COVID impact on cancer services. So we've talked about this drop-off in referrals, and this slide illustrates this even more. So a 2-week wait referral is what we call a cancer referral, because anyone referred with possible cancer, there's an obligation that the hospital sees them within 2 weeks of being referred by their GP. So we refer to it as a 2-week wait referral. And unfortunately, what COVID did was there was a lot of scaremongering going on. Rightly or wrongly, the politicians and the journalists, the message that came over, particularly in the first few months, was stay at home. And people did what they were told. They stayed at home, and that included not contacting their GPs, not wanting to bother them with anything that they felt couldn't be anything COVID related, because obviously that was the only thing that was important. That's all anyone wanted to talk about. The assumption was that all coughs were due to COVID-19, and in fact one of the biggest hits we've seen is in lung cancer referrals, because the assumptions were made by both patients and professionals that a cough was down to COVID. And in the early days we had no testing, so people just lived with their symptoms, didn't get tested to see if it was COVID, assumed it was COVID, didn't darken the doors or the telephone lines of the GPs. A lot of people thought their GP practices were closed. So the number of people who were referred dropped a lot, and therefore, when these people did finally present, unfortunately, some of those people would have found that their cancer was diagnosed at a later stage, and then the treatment options were less, and unfortunately then the outcome was poorer. Can we go on to the next slide, please?
Let's move, Louise.
And really this slide just illustrates that, our 5 biggest cancers in terms of prevalence and in terms of death rates as well in this country, skin, breast, lower GI, urology and upper GI, they were all hit the same. Okay, some tumour sites always have more referrals than others, but you can see the pattern overlays such that, everyone was seeing exactly the same across the board. Can we go to the next slide, please?
That's moving.
So the main issues in primary care was, as I've said, nobody was contacting us. And I think we in primary care had to adapt the way we were seeing people. Both in general practice and in hospitals, we were having to make sure we could socially distance people within our buildings, that we could keep people safe and also keep our staff safe. So we've had to put up all sorts of barriers between our waiting room and our reception staff, and just make sure that we can get as much as possible a one-way system in the building, so using different exit to entrance, having a controlled entry, making sure that we knew who was turning up and when, rather than just allowing people to decide and just walk in. But this meant that people were confused, and I think, as a GP, I'm aware we were so busy trying to get ourselves fit for purpose that we probably didn't communicate that very well or very quickly to our patients. And so there were lots of issues in primary care. And in hospitals too, some services like endoscopy were paused completely. It was recognised that you could get COVID through aerosol discharge, through faeces, and so things like endoscopy was very, very dangerous in terms of COVID risk. And also, there was very soon an understanding that people who had COVID did very badly with surgery.
Louise, I think my slides have been taken down. Shall I try again, Katie?
Please. Louise, I just want to stop you because we've had a question. Could you explain what endoscopy and GI is, please, just in more detail?
Sorry, yes, GPs use terrible medical speak, and that's why I'm really pleased that you've asked. So GI stands for gastrointestinal, and gastrointestinal means our anywhere between our mouth and our bottom. Cancers of the gullet, cancers of the stomach, that would be upper GI, cancers of the pancreas, cancer of the liver, again, upper GI. Lower GI is when you've got a cancer of your large intestine, your colon, or your rectum, or around your anus, all of which are incredibly common and incredibly nasty. But of course, we have got bowel screening, which is great for the lower gastrointestinal tract. In terms of endoscopy, endoscopy just refers to using a telescope to have a look at something. And if that's upper GI, that's a telescope to look at our gullet and our stomach, and actually very cleverly can go a little bit past the stomach. But if it's lower GI, that's a rather horrible telescope up the bottom, which most people find pretty horrible, but is an excellent way to have direct vision of everything that's happening in your bowel. So you can see that both of those, whether you're doing upper or lower GI endoscopy, is very risky in terms of COVID, because there's lots of body fluid mixing potentially. So you do need to be very careful to protect your workforce, and also make sure that the instruments you're using, you're not passing infection of any sort, including COVID, between your patients in an endoscopy list. I hope that answers the question. If it doesn't...
Thank you very much, Louise. Thank you.
Can I just check that people can see the slides, please?
Yes, we can see the slides.
Yes, I can see them.
See the slides.
Thank you.
So we were talking about issues for hospitals. We talked about endoscopy being paused, and there were some other services that were also paused. I think they also tried very hard in hospital to prioritise cancer, but they were prioritising first-line COVID at this first wave. And so theatres lost their ventilators to intensive care. Staff from things like infertility units were relocated into respiratory wards. I think, there were a lot of workforce issues that meant staff were not only having to deal with very sick people, but having to have very steep learning curves. It must have been a nightmare in so many ways across the hospitals. And I've talked also on the slide about reduction in staff due to isolating an illness. Again, it hit us. I would say we lost less workforce in the first wave through isolating an illness than we've lost in the second wave, because actually we're testing more, and we've got track and trace. And we have had times when some of the hospitals have really had significant numbers of staff missing, not through illness, but from having to isolate because they've been in contact with someone who's been ill or had a positive test. But also the last point on the issues that the hospital had, again, it would be the same with primary care, but definitely so in hospitals. Patients declined to go to hospital. That even if they were referred by primary care, they were often saying, no, I don't want to go to hospital. I don't want to go and have that test. It's too dangerous. Hospitals were perceived as dangerous places. And it's interesting that as a medical professional, I would always say to my patients, hospitals aren't necessarily the best place to go, because hospitals always have high infection rates of all sorts. But suddenly COVID was on everyone's mind, and that's what they were worried about. So people they chose not to go, even faced with potentially having cancer. They were saying, no, I really don't want to go to hospital. Can we have the next slide, please?
It's done, Louise.
So the next slide is about how did we respond to this. So I've touched on the fact that GPs spent a lot of time making their buildings safe, and also coming up with other ways to reach their population and be able to assess them safely. So we have absolutely not been closed at any point, but we absolutely have gone from a situation where I would say 80% of our appointments were done as face-to-face with the patient sitting in our consulting room, having a chat and doing an examination face-to-face, to
Sorry to interrupt, the slides haven't moved on again.
Oh, I'm so sorry about that. I'll try sharing again.
I'll keep talking,
Thank
trying
you,
to
Christine.
see what I'm saying, and then hopefully that'll help.
Is that back on?
Yep, got them.
So now about 80% of our work in primary care, I would say, is done virtually. I think it's been quite popular with patients, and I think they have got used to it, but it's taken a bit of time for them to get used to it. But this means that hopefully we can assess people more than just by speaking to them on the telephone. We can have eyes on them through doing a video consultation. They can send us photographs, and then we can arrange in a controlled way to bring them down to an appointment and see them face to face. And I would say any GP who has a concern about a patient potentially having a cancer symptom really does need to convert any virtual consultation into a face-to-face. But it might be that they would choose to book the patient in for some blood tests prior to seeing them face-to-face. So in some ways, when they do see them, that appointment actually is more effective because they've got some results to discuss with that patient as well. So both hospitals and GPs are trying to triage. That's a way we prioritise patients. So we work out who needs to be seen, who needs further tests. As I say, we've put all these safety measures into place, so now people can safely come to GP practices and hospitals. Just yesterday I was talking to Miss Linton, who's the lead urology consultant at Chesterfield Royal, and talking about a patient who was reluctant to go for prostate investigations. And she was saying, I have absolutely every confidence now that Chesterfield Royal has put every procedure in place to keep our patients safe, and that should not be a reason for people not going to hospital. And I know that Derby and Burton have done all these changes as well, as have all the hospitals nationally. The thing we did in terms of cancer was we took over some independent sector places. So in Clown, where I work, we've got Marlborough down the road, which is basically an orthopaedic centre, and normally just does elective procedures. But we were able to use these non-NHS sites as COVID-free sites to carry out cancer services, cancer surgery, to keep our patients safe. Because what I was going to say before we lost the slides was that patients, if they are COVID positive and they have to have surgery, we've known from very early on this year that they will do poorly after surgery if they have had COVID, if they've got COVID. So even if they're not particularly unwell with their COVID, if you then operate on them, they are at higher risk of complications post-surgery. So it's really important to keep any of our patients that require cancer surgery in COVID-free sites. Hopefully the communications got better. I know I made some videos along with Chesterfield Royal and with Cancer Alliance around trying to encourage patients to come forward. And I think our journalists gradually caught on to the fact that people didn't want to just hear stay at home, stay at home, stay at home. There were occasions when actually we wanted them to come out of their houses and come and engage in, finding out whether the symptoms they've got were significant. We've asked our hospitals to monitor activity very carefully, to look at patients who may be delayed in any of their investigation pathways or their treatment pathways, to ensure that they are getting welfare calls, the GPs are being communicated with, so the GPs are aware that patients they've referred aren't perhaps having the smoothest, quickest route through to a diagnosis or undergoing treatment, so that they can support them as well. And certainly the best thing that's come out of this year is we've seen some fabulous whole system working with GPs talking to their secondary care colleagues more, fantastic support from public health and from allied professionals. Can we go on to the next slide? Unfortunately, we are continuing, as everyone knows from the news, to see a huge number of COVID cases. Are we in a second wave going into a third wave? That's the sort of chat I'm hearing from my secondary care colleagues. But what's so fantastic is we worked so hard in the first wave that we've put so many things into place that we're coping much better this time round. And primary care, certainly we haven't seen the reduction in the referrals like we saw in wave one. In fact, in some specialties, we're seeing over the expected average for this time of year, which presumably is making up for some of the people who should have been referred earlier in the year. I think the trouble with that we are now perhaps referring even more, is that there are obviously still significant capacity issues because the hospitals are having to still respect social distancing and infection control, which means that they don't have the full capacity they had before. And you will have heard on the news that the politicians have just thrown another £1 million at sort of further investigation and things. But, at the end of the day, we've got to have the hardware to put these people into to do their MRI scan or CT scan, and we've got to have the space to be able to keep them socially distanced from each other, to keep them safe from infection. So, I'm sure the money will be helpful, but it's going to take a bit of time to have that effect on the system. Hospitals have definitely prioritised cancer services. There's been a recognition, as I said, right at the start, that, we cannot allow these undiagnosed cancers to continue to sit out there in the community, because their prognosis when they are diagnosed will be poorer because they'll be diagnosed at a later stage. We were already working in cancer services towards one-stop type rapid pathways, because we recognised that wait between referral and getting a diagnosis was awful. And knowing that we want to make every visit to the hospital count, we've moved on even further with these one-stop pathways. And that will continue once COVID is hopefully under control. Secondary care have been fantastic in offering robust advice and guidance to primary care, who are working at the bottom of the pyramid with all this undifferentiated disease, trying to find the wood from the trees. I always think my secondary care colleagues have it relatively easy, in that at least we do the first picking, but perhaps a bit unfair to them, but I like to at least feel that we're doing a good job out here and trying to find that wood from the trees. And we're trying to support, as a cancer lead in general practice, I'm trying to support my colleagues out here with some education and learning and some support tools to try and make their referring as appropriate as possible. Can we go on to the next slide? So this next slide is equally really important, because at the end of the day, it doesn't matter how well people like myself try and do our job, and how well our colleagues in secondary care try and do their job. If people don't present, that's going to just not be good news. And, we've got to get those messages out there. And so Help Us, Help You campaign is a massive exercise in getting those messages out to people to make them...
everybody.
Sorry?
Can you see the slides?
Yes, we can see them, Louise. If you just carry on. Thank you.
So really, this is a big push to say to people, that you don't have to decide how significant your symptom is. Just ring your GP, have a chat, and let them talk to you and decide whether or not you do need further investigation, and whether you do need to have concerns about cancer. Sitting at home worrying is not going to be good for you, and it's just not what we want. We want you to come forward. We want you to get a diagnosis if you have it, or hopefully to be able to reassure you that you haven't got cancer, which would be even better. So I just want to go on to the next slide, which I think is really another important thing, just to put this into context. Can the slide move on? We're still on the health.
It's moved.
Great. So before COVID came along, the national priorities for cancer were that by 2028, we wanted to see the number of patients increased with early cancer, so stage 1 and 2 cancer rather than stage 3 and 4 cancer, would increase from 50 to 75%. And the reason for this is what I've kept referring to during the presentation, is that the earlier you present, then, we're actually incredibly successful at treating cancer now. And so the earlier you present, the more treatment options we can offer you, and the better your prognosis. And then this will, we hope, improve our 1 and 5 year cancer survivorship figures, which even though we've had a knock in 2020, it's been a dreadful year and will inevitably go into 2021. I want to reassure you that in Derbyshire, we have a very clear objective to challenge ourselves to still meet these targets by 2028. We will not be saying, oh, well, we'll let that drift because we had a bad time with COVID. So we will be working to these key national priorities. And I think the next slide is just saying time for questions.
Thank you very much, Louise. We did have a question submitted, and it is, what steps would you suggest a person with cancer takes when their treatment is delayed due to the pandemic? What self-help can you suggest for cancer patients should take in terms of thinking about anxiety, depression, especially when they're worrying about their condition?
Okay, so I would always say as a GP, we are care closer to home. If you're facing a possible cancer diagnosis or you've got a cancer diagnosis and you're having treatment, then please, please, please get a relationship with someone in your primary care. It doesn't actually have to be a GP. It can be a practice nurse. We've got some excellent practice nurses. We've got some great community matrons. We've got some good care coordinators. But, that is something that you should be able to access fairly easily. But if you are on a cancer pathway and you've got a delay in your treatment, you will also have a cancer lead nurse who is your key worker. You may be lucky enough to have been introduced to or given the contact details for a cancer support worker. And all the hospitals also have information and support centres which you can access and which Joe Rhodes, one of the commissioners on the call, is going to put onto the chat so that there's telephone numbers available for people. And I would always say to you, try your primary care, because if you try the hospital and you can't get through, which is often the thing I'm told, and you're not sure of the support centre numbers, or you've forgotten them, or you've lost the piece of paper you've been given, then go and ask your GP or your practice nurse, because if they don't know the answer to the question, they certainly know who to ask and they'll be able to get back to you. So there's always someone that you can go to ask that question and access that report, that service. There is generic psychological counselling accessible from primary care, but I would say that the cancer information centres at all the hospitals have more cancer-related support, and they can also signpost you to some wonderful things like hypnotherapy, relaxation therapy, all sorts of things. I remember one of my cancer patients after her surgery was not doing very well psychologically, and I referred her to the information centre at Chesterfield, and she managed to access a wonderful ladies' day all around beauty therapy and doing your makeup, which when you've had really quite brutal surgery, I can imagine that would really knock your self-esteem. And so to go along and have a day like that with other people who understand what you've been through because they've been through similar surgery, she found it fantastic. And so please, pass on that information to anyone you know, that these information centres are absolutely, they're fantastic. They really are.
Thank you very much, Louise. We also had a question submitted around screening, which is for you, Christine. How can a patient find out what regular health screening, including cancer-related screening, how can they find out about it? What can they expect? And when should they expect to be called? And if we're looking ahead, how do we think that may change over the next 10 years? They also wanted to know what the contact point for health screening, for regular health screening is, and how does it reduce or change in terms of the pandemic, and what efforts have been made to keep patients informed. There was a particular one about bowel screening, and a question from Pete, which has now been answered, also came through the chat box. Are people still being called for their bowel screening? And if it slips, how will it be picked up? And what is the role of primary care in health screening if it's carried out in a practice, but then a hospital is involved, or if the screening is done in a hospital, but the results need to go back to the practice?
Okay, thank you. So it's quite a long question, so I'll take it in part if that's okay. So the first part of the question was around finding out what health screening programmes people can access. So I'm going to ask my colleague Joe Rhodes to put 2 links into the chat box. So the links that we're going to share with you they hold information on all the screening programmes. So certainly the .gov.uk website is really good. It lists all the screening programmes, not just the cancer ones, but all the screening programmes. And the Cancer Research UK link is an excellent link to tell you information about all the different programmes. So I think you'd have to go, it would take you quite a long time to go through each of the individual programmes. So I think if you can access the links, it lets you know by programme what age, etc., and the criteria for each of the different programmes. So hopefully you'll find those useful. So the next question was around the contact points for health screening information. Again, if you go into those links, each individual link has got because each of the different screening programmes have got different leads. So you'd have to go into the links to find out the contact details for each of those links. But please come back to us if you're finding that difficult, and we can help with that. The third part was around regular health screening. The patient who put this question forward had an issue around bowel cancer screening and delays during COVID. So I'm not able to give answers for individual cases, but it's been a really difficult time to deliver some of our screening programmes during the pandemic, especially the bowel screening programme, due to the advice from the Royal Colleges around how we deliver the service safely during the pandemic. So that did lead to some delays, unfortunately. But all of our screening programmes, they're currently working towards a restoration recovery to get them all back on track. So patients will be informed when their next appointment's due through the usual processes. The last part of the question was about the role of primary care in health screening. Obviously, GPs don't carry out all the programmes, but all of our GP surgeries have information on their patients who attend cancer screening programmes. So we do monitor how many patients have taken up the offer of screening, and GP practices work really hard towards improving the uptake to make sure as many patients as possible are screened at the right time. So they look at their data to understand what some of those barriers might be. For example, it might be because of the language we're using, or there may be difficulties with the patient not understanding the content of the letter. So through understanding what some of those barriers are, helps them to actually work with their patient populations to improve screening.
Thank you very much, Christine. Louise, I think this question is for you. I think you've already touched on it, but it's a question from Julie, and it's around concerns with treatment pathways, especially during COVID. She was saying that she's had friends where the diagnosis was delayed, and she felt that, they felt the treatment wasn't delivered promptly enough. They were both in the 60 age group, but what she was asking is, are we likely to see an increase in using private facilities to help to speed up the process? I know you mentioned Barbara. I just wondered if you wanted to add anything further.
So we continue to use the private sector for some cancer surgery, but increasingly I think the hospitals are feeling more confident about the infection control procedures that they've put into place. Christine, as a commissioner, do you know what the plans are going forward into 2021? You're on mute.
Sorry, Louise, I was just reading some of the chat box messages while you were talking there. Can you just repeat the question, Louise?
So, Julie Lowe has expressed a concern that two of her friends, unfortunately, sadly died after being diagnosed with cancer. She felt that their treatment wasn't prompt enough. And basically asking the question about were we able to increase the use of private sector for treatments to take the pressure off the acute sector. Now, obviously, we are still doing that. And I was just saying that hospitals are increasingly doing their own surgery again now because they put the infection control procedures into place. But I don't know what the plan is going forward into 2021 about how much surgery is planned, cancer surgery is planned out of our main trusts. Do you?
Yes, so there is still a contract with our independent sectors going forward into the new year. I haven't got all the contractual details, but I do know currently we've got contracts with Marlborough and Nuffield in the south, and some availability or some capacity in other trusts, in other independent sectors as well. So hopefully we should still be able to continue with that additional capacity for cancer surgery, Louise.
Okay, thank you, Christine. Louise, I think this is another one for you. Pete said, how can we communicate to people that GP practices are COVID secure? Would it be worth posting a video of a patient walking through the practice and seeing the doctor so that patients would be reassured it's safe for them to do so?
So this is interesting, Pete, because this is exactly what I did. Early on in COVID, I took my phone and recorded myself entering our new COVID-safe general practice from a patient's perspective. I'm not absolutely sure where that video ended up, because I sent it to South Yorkshire Cancer Alliance, that I also happen to be a primary care lead for, because they were making a lot of videos at the time. And I was just saying to Jo Rhodes the other day, I've not seen that. We need to find it, or I need to redo it, because I did feel it was very important. As I said right at the beginning of my presentation, for all I think general practice has done a fantastic job at changing our ways of working. What I don't think we've done such a good job of is making sure that we've communicated that adequately to our patients. And as I say, that's part of the reason I did the walkthrough video. If we can't track it down, Pete, then I'll do another one if necessary, because I do think, in the same way someone's made a comment in the chat about how powerful pictures can be rather than paragraphs of text when you're trying to get something over to someone about how things are diagnosed or how things are treated. I think these videos can be extremely powerful. And I don't know if any of you have accessed the Chesterfield Royal videos that were done early on about how they have made Chesterfield Royal extremely safe. And I know Derby City have done similar. They are very reassuring.
Would it be possible if I could just make a very quick comment there? Sorry to interrupt. This is Pete Steedman who posed that previous question. Yeah, I think that's a great idea, and it might be also good to maybe take a cross-section of patients and actually see how it is for them in terms of whether they think that sort of video approach will be better than walls of words, and just get that feedback. Thank you.
I think we have done some work talking to patient groups. I haven't. It's been done by various of the communication teams. And I think generally people would agree with you, Pete, that videos are a good idea. As I say, what we've perhaps not done, in the same way as we haven't communicated our changes perhaps as well as we could have done, perhaps we haven't posted these videos in the most obvious of places. So we need to work harder at that. But yeah, I take that on board, Pete, and I think that's something we need to do a bit better.
I'm just going to move to a question from Patricia, Louise. Pete, I know you've asked a number of questions, but I do think it's important that some of we address. We will always come back and address them later, if that's all right. But yeah, I just do need to move to some of the other people. Patricia's asked, are there any issues for cancer services and cancer patients in terms of the rollout of the vaccine?
So I think the first thing to say is that despite all the various things that are being said by different people, the vaccine is extremely safe. It is not a live vaccine. There are vaccines that we use on a day-to-day basis that are live attenuated vaccines, which we do have to be very careful about in people who've got any kind of underlying disease or a lessening of their immunity, which a lot of cancer patients have if they're on chemotherapy, for example. But the COVID vaccine isn't like that. It's a synthetic virus, a synthetic vaccine, which will be completely safe. And it's going to be very, very important to protect cancer patients because if they've got COVID and they've got cancer, they're not going to do very well. And for them to feel that they can safely engage in their treatment, having the COVID vaccine on board will also be important. So it is absolutely recognised that cancer patients will be high on the priority list. like all the other groups, that priority list will have to be worked on, and it's not clear at the moment. I mean, for all we've had all this stuff in the news about, oh, we're giving out all this vaccine, the numbers are relatively small. And as you know, they're also pretty difficult at the moment for those people who are very sick because of the way this particular vaccine that's been released has to be stored at ridiculously low temperatures. Come January, we're confident we're going to see at least one more, if not two more, vaccines come online fairly quickly that are going to be easier to get out there. But I know that the hospitals are working hard with prioritising their outpatients. So people who are going to hospital for procedures and tests and appointments, they are working hard to get those vaccinated. And so the cancer patients will be on that list. So I'm afraid I don't have specifics for you, Patricia, about exactly which cancer patients and when and how they'll do that prioritisation. But I think it is important to recognise that absolutely cancer patients do need to have the vaccine. And yes, the vaccine is completely safe for people who have cancer or who are undergoing treatment.
Thank you very much, Louise. John's asked what funds are available from cancer research. I'm not sure this is something we can answer on here, is it, Louise?
No, I think it's good to have an opportunity to say that unfortunately the cancer charities, like all the other charities, have suffered terribly. You know, a lot of these big charities, they depend on big events in order to raise their money, and all these events have been cancelled this year. And we work closely with Macmillan and Cancer Research UK, and I know of colleagues who work for both of those organisations who unfortunately have lost their jobs as a consequence of the lack of money. I was stunned just how vulnerable even these very big charities are to when the funds dry up. You know, both Cancer Research UK, Yorkshire Cancer Research UK, Macmillan, all of these big charities, Prostate Cancer UK, they all give a huge amount of money, which has an effect nationally and locally for our patients. And come 2021, we'll get back to being able to help them boost their revenue and see that money come in. But at the moment, yeah, it's been a grim year for monies to support any kind of research, which again is just not good news.
John, I know you've asked a question saying that you attended the Ageing Well, and I noticed that you put your hand up as well. Did you want to ask your question about
only to comment on the factor that many charities are losing money. Sadly, I am not singing, and our choir would have given £1,200 to a registered charity, as we did last year, to diabetes, and before that the blind and so on. And that is hurting me as much as those charities are not receiving.
All right, thank you, John. John also asked Louise that he was saying that he'd attended the Ageing Well meeting, where one of the things they talked about is perhaps encouraging patients to attend for an annual checkup, like an MOT. This would introduce the patient to the doctor and the doctor to the patient.
Yes, I think it's a difficult one, because I think if you'd asked me that a year ago, I would have said yes, absolutely. But I think the way that GPs are working now, I don't think that that's going to be as easy to access, which is a shame. There's no reason why, if you don't feel you've got a relationship with your general practice and you're usually fit and well, why you shouldn't ring in and have a chat with your GP and say, look, this is me, I'm normally well, but, you know, these things are worrying me. Do I need to, you know, what sort of things should I be looking out for? Should I be having any baseline tests? I mean, certainly, you know, I can only talk on a personal level. I would be more than happy to have that sort of conversation and do whatever I feel is necessary. I think the trouble is baseline health checks are not very good. I started out being an Air Force medical officer and they're obsessed with doing baseline health checks every year on pilots, for example. But unfortunately, it doesn't stop the pilot who has the brain hemorrhage whilst flying his rather fast jet around the skies. You know, health checks generally, unless they're directed, are not very helpful. But I think in terms of having a relationship with your GP, I do think that's important. And increasingly, as I mentioned earlier in the presentation, GPs are lucky enough to have community matrons attached to them. And I think if you are one of these fit elderly who just doesn't have a reason to come and see us, then I think you should be touching base with one of our allied professionals, even if it's not a GP, just so that we are aware what your situation is. And one of the things I remember being told on several occasions during my training was that, you know, if your circumstances change, so if you've been married to someone for 40 years and then unfortunately you lose your partner and you've always been in good health, it's on losing your partner, secondary to the grief, that we also see physical things happen as well. And it would be lovely, wouldn't it, if GPs were on the ball enough to contact you and say, you're vulnerable, come and talk to us. But we need you to ring us and tell us if you've had a change in circumstances. And so I would encourage you to do that. So although you're going to struggle to make a face-to-face appointment, there's absolutely no reason why you can't get yourself put down for telephone advice and have a chat with one of the GPs, practice nurses, whoever takes the call. I think it's important, I equally say, and this may sound madness, but it's amazing how many people don't think about it. If you want to make that sort of call, don't make it on a Monday, because you'll be on hold for a long time. So generally don't ring first thing in the morning, and don't ring on a Monday. But other than that, I would encourage you to try and touch base with your GP.
Thank you, Louise. Christine, Anne said breast screening was suspended for the over 70s. It's now been restored, but the problem was that many ladies weren't aware of that. How do you inform patients about those changes?
Yeah, that's a really difficult one to answer. So during COVID, they did suspend screening for the ladies over 70, but I do know that's back on track now. So I think for any lady who is outside of the screening age group, is able to self-refer to the service if they feel, you know, they've got a need. So they can do that through their local screening services wherever. I can't say which one because obviously there's a number of them across the county. So, but it is open. Unfortunately, I don't think there was a communication that went out to patients in the first instance during the COVID pandemic.
All right, thank you. And this is for both of you. It's from Julie. Is there any information on dentists? We know that many oral cancers are first picked up through the dentist, but they're not as yet running checkups, only emergencies. Do we have any idea, if that's had an impact and when that may change going forward? You may not be able to answer it, but I'm just asking.
So I am aware that dentists are back open. And they are doing checkups. So they closed in the first wave, which I personally found a bit bonkers because they've used PPE carefully for years, much better than we have in primary care. But as far as I'm aware, dentists now should be open. There is some restrictions on some of the procedures that they can carry out, but that doesn't include checkups. Irritatingly, from a personal perspective, you can't go and have your teeth polished by the hygienist apart from by hand, which takes a lot longer and is a lot more uncomfortable. But they will do your checkup and they will clean your teeth manually. So you would hope that oral cancers will be spotted. But yes, it was a problem in the first wave because dentists did close.
Okay, and just to say, Louise, that you may not be aware of, but we will be sharing it. The other good thing is that there have been some very positive comments in the chat as well about people who did present and did still go for their screening appointments, and that so there is some positivity. Just to say that there are only a couple of minutes left. I don't know if anybody else has a final question. Just to say that I know, for example, Pete, you raised a number of questions. Anything that we haven't answered now, we do go back and put all the answers, and that will be available on the Joined Up Care Derbyshire website with a recording of today, and also all the answers to any questions that haven't been addressed now. So I don't know if there are any final questions.
Can I just interrupt briefly?
Please.
There have been a few things in the chat about people who are obviously having problems with their dentist. As I say, I didn't say that with any authority, and I think it would be helpful if we could try and find out and put onto, add something to this when we put it onto the Joined Up Derbyshire site about what the situation is with dentists. They do obviously work fairly independently, and it is something that, I think people do need to know about. So could we do that, Katie?
Yes, absolutely. As I say, we will go through, and Miriam will have made a note that is something that we need to get some more information about from our dental commissioning team.
Yeah, absolutely.
So I just want to take this opportunity to thank both Louise today, and she also works as a GP, so a very busy time. She's taken time out, so thank you very much, Louise, and also thank you to you, Christine, for joining this session today. And to everybody who's joined, I hope you found it useful. Thank you so much for joining us. As I'm sure you're all aware, it's a very different landscape for us trying to engage with people. So we, at the moment, really the only avenues open to us are through these digital platforms. So thank you to everybody who's joined. Our next session in the new year will be around 111 first, but we will send out more information about that. So thank you very much indeed, everybody, to joining. Thank you, Christine, and thank you, Louise. And to everybody here, have a lovely Christmas and a new year, whatever you're able to do. Thank you very much.
Thanks so much, everyone.
Thank you all. Thank you.
Goodbye, everybody.
Thank
Cheers
you.
now.
Bye.
Goodbye.
Thank you.
Bye.
Bye-bye.
Bye.
Bye.
Bye, thank you.